Mathematical modelling released this week says South Africa is likely to see about 40,000 deaths from COVID-19 by November. One of the consequences of this would be a shortage of hospital beds, particularly in ICU wards. I want to explore that a little with Dr. Gesine Meyer-Rath, a physician, health economist and infectious diseases modeller, currently attached to the Health Economics and Epidemiology Research Office at Wits University here in Johannesburg, joining us via Skype with a view on the current modelling. Doctor, good afternoon to you and welcome. I want to explore, first of all, if we can, about how COVID-19 data is modelled. We tend, I think, in this media business to focus on the big headline numbers, little understanding perhaps of how we get there, and often we'll take that big number and treat it as gospel. But all of these numbers, the data, is adaptable, I would imagine, almost on a day-to-day basis.
That is absolutely correct. Thank you, and good afternoon to you and your viewers. Models are mathematical crooks to help us understand something that we can't quite see just from looking at the data that we have at our use at the moment. So what we do with models is we look at the data, we try to be very clear about the patterns and the relationships between the data that we see, and then we extrapolate from there into a future. And we do this only very begrudgingly because we don't really like the uncertainty that comes with modeling, especially months and perhaps years in advance, especially if we only have 1.5 months worth of data, as in the case of COVID-19. We do this only because there are decisions that have to be made. In our case, for the COVID modeling consortium, the request was from government to supply data that could also then be used to budget for the COVID health response. And that, of course, needs certain time periods, which is why we are modeling over 6 months.
So when we see figures of a possible 1 million cases by July, how much credence then would you be lending to that model?
So those are our numbers. These are active cases. So, and that's quite important to remember. People have been criticizing that number as being far too low. And that is because it's active cases. If you look at today's numbers, we are sitting at somewhere around 7,800 active cases that are basically people who have COVID symptoms right now. At the same time, we have another number that's 17,000 cases. That is all the cases we've ever seen from the beginning. So that's what we call cumulative, because we accumulate them over time. And when it comes to the cumulative numbers that we project at peak, sometime between August and September, that's a far higher number. That's 12 to 14 million. And that is probably the number that makes more sense to people because, that 17,000, that's what we wake up in the morning and check first and, get quite upset about. Of course, each of those is an actual life that is probably right now being disrupted in some way. So we believe that at peak, we will have an increase of a 1,000-fold increase in cases. And that, of course, is a very, very strong assumption. Basically, this is still a subset of basically only those people who are symptomatic. We think that's only 25% of all cases. So altogether, we believe that way above 80% of South Africans will have exposure and will be infected with the virus before it turns. That's a strong assumption. It might well be wrong.
Dr. Meyer-Rath, just one final question then. Your big concern then is ICU beds and ICU equipment as we head to the peak. Do we have enough? How many do we have? How do we plan for this?
So at the moment, we believe we have about between 3,000 and 4,000 ICU beds. 2/3 of those are in the private sector. When under the COVID surge, so essentially when we have that peak of cases, it will probably no longer matter much if you're in the public or the private sector because we will be having to pool resources. We believe that at peak, and should our projections come to pass, we will be looking at between 25,000 and 35,000 ICU beds that we need. Now, it's not just the beds, it's really the critical care space. So you need additional oxygen for quite a number of the patients. Some of them will require ventilators, which we also currently have perhaps between 3,000 and 4,000. There are projects underway to make in-country additional ventilators, at least for non-invasive ventilation. So that's all very good, and part of that is based on our data, which we are fully aware are news to the general public and shocking, but have been in front of government departments for weeks now. So they have started planning way in advance. And there's a certain number of attempts to actually increase this capacity that have already borne fruit.
And we will leave it there. Dr. Gesine Meyer-Rath from the Wits University's Health Economics and Epidemiology Research Office. Thank you for joining us.